Welcome back to The Deep Dive. Today, we're embarking on a journey into a truly vital and, let's face it, often complex subject: mental health, mental illness, and the intricate world of mental health care.
Right.
We've gone through a really rich stack of sources, from foundational concepts to critical care insights.
Yeah, quite a bit of material.
And our goal is to, well, cut through the noise and give you the essential understanding. Okay, let's unpack this.
Absolutely. Our mission today really is to distill the crucial insights, maybe some surprising facts, and just the practical understanding from all this.
Like a shortcut.
Exactly. Think of it as your shortcut to being genuinely well-informed on a topic that, it touches everyone's lives, right?
For sure.
We're going to
Yeah.
try and connect the dots, between the big ideas and the specific details,
Yeah.
helping you understand not just what these things are, but why they deeply matter to you.
Absolutely. So let's start right at the beginning. What exactly is mental health? Our sources suggest it's far more than just not being ill.
Right. It's not just the absence of sickness.
It's this incredibly active, dynamic state, almost like a muscle you're continually flexing. It's about being able to realize your own abilities, cope with life's everyday stresses, work productively, and, actively contribute to your community.
It's less about avoiding sickness and more about kind of cultivating that sense of well-being.
Exactly. And that's a crucial distinction from mental illness, isn't it?
It really is. Mental illness is, well, it's a diagnosable disorder. We're talking about significant disturbances in cognition, emotion regulation, or behavior.
Things that really impair functioning.
Right. They meaningfully impair your daily life. And what's fascinating here, and I think often misunderstood, is this concept of a mental health continuum.
Yeah. Not just on or off.
Precisely. It's not a switch. You're not just healthy or sick. It's more of a fluid spectrum. We're all kind of constantly moving along it based on life events, stress, our circumstances.
That really brings it to life. We're all in motion along that line. So what actually influences where we land on that spectrum?
Well, the sources point to a blend of factors, sort of pushes and pulls.
Okay, like what? Risk factors.
Exactly. On one side, you have risk factors, things like genetics, maybe past trauma, substance use, chronic illness.
Even things like poverty or unstable housing.
Definitely. Socioeconomic challenges.
Mhm.
And ACEs, adverse childhood experiences, big ones.
Right. But then on the flip side,
You have the protective factors. These are the buffers, the things that help shield us.
like having good support.
Strong support systems, yeah.
Oh.
Education, stable employment, healthy ways of coping with stress, and crucially, access to healthcare.
And that leads to resilience, right?
It builds on it, yes.
Mm-hmm.
The idea of resilience, not just bouncing back from adversity, but maybe even growing stronger through it. It's a capacity that's built through those very supports, those coping skills, and a sense of personal empowerment.
Okay, here's where it gets really interesting, I think. The diathesis stress model.
Yes.
I sort of think of this as nature and nurture working hand in hand.
That's a great way to put it. It suggests that psychiatric disorders aren't usually about just one or the other.
It's the combo.
It's the combination. You have a genetic or biological predisposition, that's the diathesis, and then you have environmental stress interacting with it.
So someone could be more vulnerable.
Right. Someone with a high diathesis, a strong inherent vulnerability, might develop a disorder even with relatively mild life stress.
Whereas someone else might need major stress.
Exactly. A person with a lower predisposition might only show symptoms if they face really severe or prolonged stress. And importantly, even with a predisposition, strong protective factors like good support, healthy coping might mean they never develop the disorder.
That's such a crucial reframe.
It really is. It fundamentally shifts how we think about mental illness.
Yeah.
It's not about being broken or weak. It's this complex interplay.
And it raises an important question for you, the listener. How does understanding this model maybe change your perspective?
Yeah, it puts power back into managing our environment, building resilience.
Okay, that makes mental illness feel less like a personal feeling.
Precisely.
So having explored that broad landscape, let's maybe zoom in a bit on the brain itself, the role of neurotransmitters, those chemical messengers.
Yeah, let's get into the chemistry. Think of these brain chemicals like the brain's internal communication network.
Or
Maybe an orchestra.
an orchestra, I like that.
Yeah. So dopamine, for instance, is like the conductor for motivation, reward, even movement. Too much, and the music gets chaotic, maybe linked to psychosis.
And too little.
And too little, the orchestra kind of falls flat, which we might see in depression.
Okay. What about others? Serotonin.
Serotonin, right?
Yeah.
That helps tune our mood, sleep, appetite. Imbalances there are often connected to anxiety and depression. There's also norepinephrine for alertness and mood, and GABA, which generally has a calming effect.
So understanding the orchestra helps understand treatments.
It does. It helps us grasp why treatments sometimes target these specific players, these neurotransmitters.
Fascinating how these tiny chemicals have such a massive impact. Okay, so moving into psychopharmacology or medications, we want to stress understanding the implications here, right? Not just memorizing drug names.
Absolutely. It's about the critical effects.
Like with antidepressants, our sources really highlight that black box warning.
Yes, that's vital. The increased risk of suicide, particularly in adolescents and young adults, especially during the first few weeks of treatment.
And that's before their mood even starts to lift, which seems counterintuitive.
It does, but it's a critical window to be aware of. Safety first.
Okay. What else is critical regarding meds?
Well, lithium toxicity is another big one. Lithium's great for bipolar disorder, but it has a very narrow therapeutic window.
Meaning the safe dose and the toxic dose are really close.
Exactly. Tiny difference. That's why regular blood tests are absolutely non-negotiable. Signs of toxicity can start mild tremors, confusion, stomach upset, but can become severe, like seizures or kidney damage.
Wow. Okay. That's serious.
It is. Then there's serotonin syndrome. This can happen if you combine certain drugs that boost serotonin. It's potentially life-threatening.
An overload, basically.
Essentially, yeah.
Yeah.
Symptoms escalate. Agitation, confusion, rapid heart rate, muscle rigidity, high fever. It's why doctors are so careful about what meds are taken together.
And what about side effects from older antipsychotics?
Right, you might hear about extrapyramidal symptoms or EPS, things like muscle spasms, restlessness, and a particularly concerning one is tardive dyskinesia.
What's that?
It involves involuntary repetitive movements, often of the face, like lip smacking, grimacing, tongue thrusting. And the really tough part is it can be irreversible.
Oh, wow.
Yeah. And there are rarer but very serious reactions too, like neuroleptic malignant syndrome, NMS, with high fever and rigidity, or a granulocytosis, a dangerous drop in white blood cells, especially linked to the drug clozapine, which needs constant blood monitoring.
So what does this all mean for you, the listener, when you hear about these medications?
Well, it means having an informed perspective, understanding these are powerful tools, right? They require careful management.
It's not about being scared of them.
Not at all. It's about ensuring safety and effectiveness. Knowing the warnings helps do that.
Okay. So let's zoom out again. Let's look at the bigger picture, the ecosystem of care. How people actually get help.
Right. Our sources talk about different levels of care.
Like outpatient versus inpatient.
Exactly. It ranges from outpatient services, least restrictive, most autonomy, up through things like IOPs, intensive outpatient programs, or partial hospitalization.
More support, but not 247.
Right. And then all the way to inpatient care, which is 247 support for acute risk situations.
And sometimes involuntary commitment comes into play for safety.
Yes, things like, for example, Georgia's 1013 form for a temporary hold. These are safety nets for acute crises.
Crucial to all of this, though, are patient rights.
Absolutely fundamental. The right to informed consent, the right to refuse meds, with some exceptions in emergencies, privacy, humane care, and always aiming for the least restrictive care possible. Ethical treatment hinges on these.
Definitely. And at the heart of it all is the therapeutic relationship.
The core, really.
Our sources emphasize things like trust, empathy, genuineness, and this idea of unconditional positive regard.
Yes, that's Carl Rogers. It means accepting and respecting the person fully, no matter what they say or do, creating that truly safe space.
Where they feel seen, heard, not judged.
Exactly. And boundaries are key here, too. Keeping it professional, focused on the patient's well-being, avoiding dual roles.
Makes sense. And how do these relationships typically unfold?
Well, Peplau described phases. There's pre-orientation before you even meet. Then orientation, getting to know each other, setting goals, the working phase, actively addressing those goals, and finally, termination, the planned ending.
And sometimes things get complicated, like transference.
Right. Transference is when the patient unconsciously projects feelings from past relationships onto the professional. And countertransference is when the professional does the same back.
So awareness is key for the professional.
Absolutely. Self-awareness is crucial to manage that and keep the focus therapeutic.
And central to all this is just good communication.
Could be more important. Techniques like active listening, really hearing someone using silence effectively.
Letting them think or feel.
Yes. Paraphrasing to check understanding, reflecting
Ah.
feelings, asking open-ended questions to explore things further.
What about things to avoid in communication?
Good question. Giving direct advice often isn't helpful. It can disempower. Offering false reassurance dismisses their real feelings.
Like saying, don't worry, everything will be fine.
Exactly. And asking why questions can feel judgmental, put people on the defensive. Why did you do that? Isn't usually productive.
And nonverbals matter hugely too, right?
Oh, immensely.
Yeah.
Your tone, your posture, your facial expression, sometimes they speak louder than words.
Hmm.
It comes back to that idea of listening without fixing, just being present.
Okay. Now let's dive into some specific mental health challenges. Maybe pull out some unique symptoms or surprising facts from the sources.
Sounds good. Where should we start?
How about schizophrenia? We often hear about positive and negative symptoms.
Right. It can be a bit confusing terminology. Positive symptoms aren't good symptoms. They're things that are added or present but shouldn't be.
Like hallucinations.
Yeah.
Seeing or hearing things that aren't there.
Exactly. Hallucinations or delusions. Those fixed, false beliefs that are resistant to evidence, disorganized thoughts or speech fall here too.
And negative symptoms.
Negative symptoms are the absence or reduction of things that should be there, like flat affect, reduced emotional expression, anhedonia, difficulty feeling pleasure, avolition, lack of motivation.
Things are missing, basically.
Precisely. And one really critical aspect which often surprises people is anosognosia.
What is that again?
It's a lack of insight or awareness of one's own illness. The person genuinely doesn't recognize they're sick, even when it's obvious to others.
That must make treatment incredibly difficult.
It's a major challenge for engagement, absolutely. Imagine trying to treat someone who doesn't believe they need treatment.
Okay, moving on to bipolar disorders. Different types, but the core is mood shifts, right?
Exactly. Significant shifts in mood, energy, activity levels. Bipolar I involves episodes of full mania, that distinct period of elevated or irritable mood and high energy, often alternating with major depressive episodes.
Bipolar II is different.
Bipolar II involves hypomania, a less intense form of mania, plus major depressive episodes. And cyclothymia is sort of milder, longer-lasting ups and downs.
What does mania actually look like?
Key signs include things like pressured speech, talking really fast, intensely, hard to interrupt, significantly less need for sleep, high distractibility, engaging in risky behaviors they wouldn't normally.
Grandiosity, too.
Yes, an inflated sense of self-importance. And flight of ideas, thoughts racing.
And we mentioned lithium earlier for bipolar, that narrow therapeutic window.
Yes, bears repeating. Vigilant monitoring for toxicity is crucial. Early signs like stomach upset or fine tremor can progress to confusion, seizures, coarse tremors, if not caught.
Got it. Okay, anxiety disorders. This isn't just one thing either, right? There are levels.
Definitely. Anxiety exists on a continuum. Mild anxiety can actually sharpen focus. Moderate narrows it. Severe anxiety leads to disorganized thinking.
And panic.
And panic is overwhelming, where someone might feel completely unable to function, like they're losing control or having a heart attack.
What are some common types?
Well, there's generalized anxiety disorder, GAD, that persistent excessive worry about lots of different things. Panic disorder involves recurrent unexpected panic attacks.
Phobias, OCD.
Phobias are intense, irrational fears of specific things or situations. OCD, obsessive-compulsive disorder, involves obsessions, intrusive thoughts, and compulsions, repetitive behaviors to reduce the anxiety, like being stuck in a loop. And social anxiety disorder is intense fear of judgment in social situations.
Are there specific meds for anxiety?
Yes, anxiolytics.
Yeah.
We often hear about benzodiazepines, like Valium or Xanax. They work quickly, but carry risks of dependence and tolerance, so they're usually for short-term use.
What about longer term?
Something like Buspirone, Buspar, is often preferred. It takes longer to work, but it's generally safer for long-term management, less risk of dependence.
Okay. How about trauma and dissociative disorders? PTSD comes to mind first.
Right. Post-traumatic stress disorder, PTSD symptoms, often include nightmares, flashbacks where the trauma feels like it's happening again, hypervigilance, being constantly on edge, emotional numbness, and avoiding reminders of the trauma.
And dissociative identity disorder, DID.
Yes,
Yeah.
DD. This is where the mind, usually in response to severe, overwhelming trauma, creates distinct identities or alters as a coping mechanism.
Leading to memory gaps.
Exactly. Significant memory gaps between alters, and the person can seem like very different people at different times. The goal of therapy is usually integration, helping these parts work together.
And for moments of intense distress, like flashbacks or feeling disconnected, grounding techniques.
Yes, grounding techniques are vital. They help pull you back into the present moment. The 5-4-3-2-1 senses strategy is a classic.
Remind us how that works.
You intentionally notice 5 things you can see right now, 4 things you can physically feel or touch, 3 things you can hear, 2 things you can smell, and 1 thing you can taste.
It anchors you in the here and now.
Exactly. Really helpful for depersonalization, feeling detached from yourself, or derealization, feeling the world isn't real. Interrupts that spiral.
Good tool. Okay, eating disorders. Anorexia first.
Anorexia nervosa, characterized by severe food restriction, an intense fear of gaining weight, distorted body image, and usually a significantly low BMI.
And there are physical signs too, right? Serious ones.
Very serious. Things like bradycardia, dangerously slow heart rate, electrolyte imbalances, which can affect the heart, and sometimes lanugo, that fine body hair that grows as the body tries to conserve heat.
What about bulimia?
Bulimia nervosa. This involves cycles of binge eating, consuming large amounts of food, followed by compensatory behaviors like purging, vomiting, laxatives, or excessive exercise.
But they might seem normal weight.
Often, yes, which can make it harder to detect, but the physical consequences are still severe. Electrolyte imbalances, especially low potassium, dental erosion from stomach acid, swollen salivary glands giving that puffy cheek look.
And that specific sign on the knuckles.
Right, Russell sign. Calluses or scars on the knuckles from repeatedly inducing vomiting.
And binge eating disorder.
Binge eating disorder, BED. This involves recurrent episodes of binge eating, but without the regular compensatory behaviors seen in bulimia.
So often associated with being overweight.
Yes, frequently. And it carries significant health risks like type 2 diabetes, high blood pressure, heart disease.
Okay. Shifting now to some incredibly important, though difficult, topics. Vulnerability and protection. Starting with suicide.
A critical conversation to have.
What are the key risk factors the sources point to?
Existing psychiatric illnesses are a major one, especially depression, bipolar disorder, substance use disorders. Also, a history of trauma or abuse, recent significant losses job, relationship, death, chronic illness or pain.
And access to means.
And access to lethal means, yes. Also, things like family history of suicide or previous attempts.
But there are protective factors too.
Absolutely. Things that buffer against risk. Strong social support, positive coping skills, access to effective mental health care, feeling connected to community, school, work, or faith. Reasons for living.
And it's important to bust some myths here, asking about suicide.
Does not increase risk. It can actually reduce it by opening the door for help. It shows you care enough to ask correctly.
And most people do give clues.
Most suicidal people do give warning signs, whether verbal, I can't go on, or behavioral, giving away possessions, withdrawing. And statistically, while females attempt suicide more often, males are more likely to die by suicide, often due to using more lethal methods.
How is lethality assessed?
It considers the method chosen. High lethality plans might involve firearms or hanging. Moderate could be overdoses with pills. Lower might be superficial cutting, though any self-harm needs attention.
And safety in a care setting.
Paramount. Things like using plastic utensils, maybe not having a private room, searching belongings for potential hazards, sharp objects, cords. Communication is key. Calm, direct, non-judgmental. Avoid false reassurance. Validate their pain. Instill hope that help is possible.
Okay. Let's move to abuse, another really tough but vital area.
Yes, pervasive and damaging.
Are there general signs we should be aware of?
Across ages. Things like inconsistent explanations for injuries, delaying seeking treatment, fearful or withdrawn behavior, maybe flinching easily.
What about specifically in children?
Unexplained bruises, especially in patterns or unusual places. A sudden fear of going home or specific adults. Abrupt changes in behavior like becoming aggressive, withdrawn, or exhibiting sexualized behavior beyond their age. Wearing long sleeves in hot weather could hide injuries.
And in adults. Maybe intimate partner violence.
Frequent ER visits for vague complaints. Low self-esteem. A partner who is overly controlling, isolates them, or insists on answering all questions.
What about elder abuse?
Unexplained injuries again. Fear or anxiety around a caregiver. Sudden changes in finances or wills. Neglect signs like poor hygiene or untreated medical issues.
And for healthcare professionals, there's mandated reporting.
A critical legal and ethical duty. Mandated reporting requires professionals to report suspected abuse or neglect, especially for vulnerable populations. Children, the elderly, individuals with disabilities?
Suspicion is enough, not proof.
Generally, yes. The threshold is suspicion. In many places, like Georgia, Nurses have 24 hours to report suspected child or elder abuse.
What about intimate partner violence? Is that always reported?
It's nuanced. For competent adults, reporting IPV without their consent can be complex and sometimes not mandated unless specific conditions are met, like if the victim is incapacitated, under 17 or over 65 in some states, or if a felony weapon was involved. It varies by jurisdiction.
Okay. Finally, on these critical issues, human trafficking, often hidden, right?
Very often, and deeply serious. The core definition involves using force, fraud, or coercion to compel someone into commercial sex acts or labor against their will.
And it doesn't have to involve crossing borders.
Absolutely not. That's a common misconception. It can happen anywhere, within any community. And age doesn't matter. Adults can be trafficked too.
And for children, the definition is even broader in some places.
Yes. For instance, Georgia law specifies that a child receiving anything of value, food, money, drugs, shelter, in exchange for sex is considered sex trafficking, regardless of whether force or coercion was used. The exchange itself is inherently exploitative.
How are people recruited? It's not always obvious, is it?
Rarely. Recruiters use deception, false job ads, modeling, dancing, social media grooming, building trust, showering with attention and gifts, targeting vulnerabilities.
Where does this happen?
Everywhere. Schools, malls, bus stations, online platforms, anywhere potential victims could be approached.
And there's a grooming process.
Yes, it's often methodical. Targeting and trust building first. Then isolation from their support systems. Then the abuse and control begins, often with threats against them or their family.
And that leads to a trauma bond.
Often, yes. A trauma bond is that confusing emotional attachment the victim develops to the abuser due to intermittent reinforcement periods of kindness mixed with the abuse. It makes leaving incredibly difficult.
So what are the warning signs people should look for?
Behaviorally, being accompanied by someone controlling who speaks for them, seeming fearful, anxious, withdrawn, unusual sexual behavior for their age, physically, signs of abuse, delayed medical care, STDs, malnutrition, maybe branding tattoos. Contextually, history of running away, instability, not being allowed to speak freely.
If someone suspects this, what should they do?
In a healthcare setting, notify a supervisor, social worker, or designated person immediately. Follow protocol. Outside of that setting, call law enforcement or the National Human Trafficking Hotline right away. Don't try to intervene directly yourself.
Okay. Heavy but crucial information. Let's shift gears now towards more holistic perspectives, starting with dying, death, and grieving.
A universal human experience, and one where compassionate care is paramount.
What's the core role for someone supporting a person at the end of life or their family?
It's really about providing dignity, supporting families in processing what's happening, helping them perhaps shape positive final memories, and fundamentally recognizing that grief is incredibly individual. There's no timeline, no single right way.
And advanced directives, planning ahead.
Important tools. Advanced directives are those legal documents outlining medical wishes if someone can't speak for themselves, like a living will or healthcare power of attorney.
Can nurses help write them?
They can and should discuss options and provide information, but actually writing or witnessing them can be a conflict of interest. Better to involve social work or legal counsel for the formal documentation.
Okay. In grief itself, Kubler-Ross's stages.
Denial, anger, bargaining, depression, acceptance. Yes, widely known, but it's crucial to remember it's not a neat linear process.
People bounce around.
Exactly. They move back and forth, skip stages, revisit them. It's more of a framework than a strict path. And it's important to distinguish grief from clinical depression.
How are they different?
Grief is a direct response to loss, tends to come in waves, usually improves gradually, and self-esteem typically remains intact. Depression might lack a clear trigger, is more pervasive and persistent sadness, can worsen without help, and often involves feelings of worthlessness and significant impairment.
As someone gets very close to the end, what physical changes might happen?
Skin might become mottled or cool. Blood pressure often decreases. Breathing patterns can change, sometimes with that death rattle sound due to secretions.
But hearing lasts longest.
That's the key insight, yes.
Yeah.
Hearing is believed to be the last sense to go. So even if someone seems unresponsive, keep talking to them gently, play music they love, reassure them. Your presence matters.
How best to communicate with someone grieving or dying?
Be present. Often, silence and just being there is more helpful than words. Use empathy. This must be so difficult. Avoid cliches like they're in a better place or giving advice. Let them express whatever emotion they're feeling without judgment. For the dying person specifically, soft, Tone, open-ended questions like, what's on your mind? Or what's most important to you right now? Simple reassurances like, you are not alone.
That nursing tip again. Listening without fixing.
It's fundamental here. Just bearing witness to their experience can be incredibly therapeutic.
Okay. Finally, let's briefly touch on older adults and mental illness. Cultural views on aging matter, don't they?
Hugely. Whether a culture reveres elders or views aging negatively impacts everything from self-esteem to access to care.
And this ties into that issue of transinstitutionalization.
It can. Transinstitutionalization is that sad phenomenon where, often due to deinstitutionalization without adequate community support, people with mental illness move from psychiatric hospitals into jails, nursing homes, or homelessness.
Where does that happen?
Underfunded community services, lack of affordable housing, stigma, fragmented care systems, it's complex. Older adults with mental illness can be particularly vulnerable.
And ageism is a factor, too.
Definitely. Ageism, those stereotypes and discrimination based on age, can lead to healthcare providers dismissing symptoms as just old age, resulting in misdiagnoses and inadequate treatment. Lowered expectations become self-fulfilling.
So communication needs to be respectful.
Absolutely. Therapeutic, non-patronizing language. If an older adult says something like, it feels like I'm just fading away, a good response isn't, oh, don't be silly, but rather, it sounds like you're having a hard time. Tell me more about that feeling.
Avoid those dismissive phrases or overly familiar nicknames.
Right. Treat them as individuals with valuable life experience. There are also helpful assessment tools like SPICES, which screens for common geriatric issues. Sleep problems, problems eating, incontinence, confusion, evidence of falls, skin breakdown. A quick check for potential issues.
Wow, okay. We have covered a truly vast amount of ground today. From the very definition of mental health, brain chemistry, meds, care systems,
Specific disorders, trauma, abuse, trafficking.
all the way to end-of-life care and issues facing older adults. It's complex, no doubt, but so incredibly important.
It really is. And as we wrap up, the reason understanding all these facets matters for you, the listener. It's about empowerment. For your own awareness, for supporting people you care about, for being a more informed voice in your community.
Connecting it to the bigger picture.
If we connect this to the bigger picture, yeah, this understanding can make you more empathetic, better able to challenge stigma, and maybe even advocate for better, more holistic care for everyone.
Absolutely. So as you go about your day, here's a final thought for you to mull over, something building on everything we've unpacked. Remember, mental well-being isn't some fixed destination we arrive at. It's a dynamic, ongoing journey, constantly influenced by our biology, our environment, our relationships, even societal structures. So knowing that, what simple shift in perspective, or maybe even one small action, can you make today that reflects this deeper, more interconnected understanding? Thank you so much for embarking on this deep dive with us today. Keep that curiosity alive.